I have not done objectives for the schizophrenia, and I've got some tables in mind that I'll create for you, but it was too much. Okay, so the first thing I want to show you today is a video. When we were talking about Parkinsonism, and we were talking about the motor complications due to levodopa and the dopamine agonist, those were like the on-off, the off, the freezing. And in my table, I just violated one of my cardinal rules. Don't put something in your handout that you don't know what it is. But I did. So that rhythmic cues and stepping over techniques that I mentioned, I told you I'd ask Marie Jones what those were, and so she told me what the physical therapists do with those. It is mostly related to gait training, or the stepping over teaches patients how to, as they're coming up on an object. And you'll notice in the video, the guy, when he's trying to get over the threshold, he has trouble. So they teach them how to anticipate an obstacle and maneuver around it or over it. But the rhythmic cueing is use of dance to help patients reclaim their gait. And this is just incredible. And I'm going to play it to the end because I don't cry very easily, but this brought tears to my eyes. It's just so incredible. It's well worth watching. Practice this because I just cannot seem to ever remember how to do it.
Hold down control.
Huh?
Hold down the
Try-
control button and then click it with the mouse.
Oh, the control? Really?
Oh.
Well, I've given you several because I was so fascinated by this technique that I've given you several, but this is the one I want.
It doesn't look like it's a link. You might have to copy and paste it.
Yeah. It's not, oh.
Okay.
Exit this slideshow. Oh, that's good.
No, but they're saying, I thought I
You gotta get out of the slideshow.
Oh, gosh. Okay, it's the one before it.
Gotta get out of the slideshow. There we
It's
go.
the second slide. Yeah, I can see I need that.
Oh, that was on an hyperlink.
Yeah.
I thought it was my phone.
Okay. Okay, now listen to this is a physical therapist.
Came across. It's actually been out for quite a while, but I didn't know about it, so I wanted to,
Can you hear it back
just
just
like this guy. We're going to demonstrate walking with no music first, just to kind of show the gait pattern. He's got Parkinson's, and so usually, he's got the typical kind of shuffling gait pattern and difficulty with smooth gait cadence. Then also video with the music, and you'll see the difference. Yeah.
He was Parkinson's gait, he was shuffling feet, he's leaning forward.
And pick up a tennis ball. Forgot about that.
Now watch him try to get over this threshold. See how he has to move, then move his feet
catch up with it.
Uh-huh.
Okay, so now we're going to do gait training with music. Everybody's got cell phones. Everybody nowadays has music on their phone, so it's just kind of a really easy way to do it. So stand here for a minute. We'll get the rhythm. Once we feel it, then we'll take off.
Oh, wow.
He's just associated it with music.
It gets better.
How do I do this?
He starts kind of moving,
He's
dancing.
like dancing. He did this before.
Isn't that incredible?
No, right?
Yeah, that you straight over that.
Do they know why?
She said there's theories that she couldn't explain to me. It actually stimulates other parts of the brain. Now see, now he's been out his walker. And it gets even better.
He's about to start dancing.
See something?
I think he's singing too.
No.
Oh, wow. He's like, I don't need that.
Yeah.
I don't need that.
Oh my gosh, I'm gonna cry.
There you go.
Okay.
She's like,
So I gave you two others that have some other types of training that they use. And then there's a, also I gave you a TED Talk, and it's a guy who had he was told he had Parkinsonism, and they told him you got about 5 years of good functioning and then you'll probably need nursing care, and he was like, I'm not gonna live that way. So he went out and learned how to ballroom dance. And he's now 7 years out when he does the TED Talk, and at the end he has his partner come up and they do a ballroom dance. It's worth watching. So I just thought this was so good, so I thought when I get old and decrepit and you all are talking to me, just put my headphones on and let Lady Gaga and Harry Styles let them do their magic. So I thought those were great. I didn't care.
What's gonna happen is I'm really just gonna put you in a home.
Maria Jones told me that they now make an app for patients with Parkinsonism. It's called like Parkinsong or something, and it measures like the stride length, and I don't know it all, but it's used as a tool to help train them and give them feedback. So just amazing stuff. I just thought that was incredible. Okay. All right. So let's start with lithium. Let's pick up with the new handout. Okay. So lithium is really an unusual drug. It's in the periodic table. It's that furthest left-hand column. So it's like where sodium, potassium fall, it's all in there. So you see similar, so the sodium and lithium really interact when you get into pumps or places in the body where lithium and so where sodium is, lithium often will be involved in those pumps, or it'll get caught up in them, and sometimes some of the side effects are due to the similarity of the two. So this is new, so if you're looking around or didn't realize, this is going to replace what I had given you a couple of days ago. Just like sodium, this drug is widely distributed, and we're going to see it from the side effect profile. It affects everything. And it can actually change organ function over time and cause, like with the kidneys, it can cause irreversible kidney damage and changes. So first line, you've learned that it's the first line for acute mania. It can be used in the maintenance of bipolar disease as well. Its clinical effect, it's really good. I mean, the 80% response rate in an acute mania. The other thing, look down at that third bullet. It reduces the risk of suicide by 8 to 10-fold. So it's very impressive in its effects. Long-term, patients have fewer episodes, longer good functioning or euthymic timelines, and patients who have a family history of bipolar, whose relatives responded well to lithium, usually have a higher response rate as well. Contraindications, there aren't that many, but one is note that don't use them with calcium channel blockers because it increases the risk of neurotoxicity and cardiotoxicity as well. And if the patient's going to undergo an electric shock therapy, then the drug should be discontinued before and not resumed for a few days after that treatment. So baseline workup is important because the drug has so many side effects. So here are the things that are needed prior to starting somebody on lithium. One is a urinalysis. One is to get a baseline serum creatinine BUN, know what the drug is or what the kidney status is. TSH, because hypothyroidism is very common with this drug. And it tends to affect people more that already have maybe an undiagnosed or unknown underlying thyroid disease. One, a calcium, because this drug will increase parathyroid hormone. Well, actually, it causes the parathyroid glands to hypertrophy, and so they put out more parathyroid hormone. One, an EKG, especially in high-risk patients who already have pre-existing heart disease, who are very high risk for heart disease. And then a pregnancy test, because the drug is considered teratogenic. In terms of monitoring, lithium is one of those drugs that has a narrow therapeutic index. So what does that mean?
It's easy to overdose.
So the range in the blood that produces the therapeutic effect and outcome you want overlaps or is right next to the same blood concentrations that can lead to toxicity. So this one has a really narrow. The serum concentration that we shoot for is 0.6 to 1.2. Above 2 milliequivalents per liter, you start to see toxicities. So note also when you should draw a level. A level needs to be drawn if you're going to do a lithium level right before a next dosing interval. So it would be like the trough. So 12 hours, because you usually dose the drug about 2 to 3 times a day unless we're using an extended release. You're going to monitor frequently. It takes about 5 days to get to steady state, so you're going to monitor frequently in the beginning. And once patients get stabilized, you can back off to every 6 to 12 months, unless there's something that changes. Patient status changes, drugs are added, the patient is exhibiting toxicity, then you would do it more frequently. Okay. So let's look at the side effects. We're going to look at acute, and then we're going to look at chronic. So there are some interventions that we can take with acute therapy that kind of apply to most of these that we're going to discuss. So often patients will do better if you lower the dose, or if you have them take it with food, especially in the beginning, because nausea is a major problem. Going to extended release products sometimes will help. On the other hand, sometimes you have to move away from extended release products back to immediate release, give smaller doses throughout the day. Sometimes people do better that way as well. And the other one is to dose them at bedtime. Some side effects do better if you can sleep through them and they don't bother you so much during the day. Here are the acute side effects. Nausea, very common in the beginning. A tremor in the beginning that usually will go away. Polyuria, which is a early sign of a nephrogenic diabetes insipidus that this drug can cause. Weight gain is common, up to 10 pounds for a lot of people. Loose stools, diarrhea can be a complaint. And then cognitive impairment. This actually will improve over time, but it can also be a symptom of toxicity, so it's a hard one. So apathy, not really caring about what happens or not happens. Decreased creativity, changes in verbal learning, memory, concentration. Those are dose related, so as you're titrating dose, when you start the drug and titrate, then that's where those may appear. Over time, they usually resolve. So let's start with GI distress, very common, so nausea, vomiting, diarrhea, upset stomach, abdominal cramping, all of those can take place. The way to treat them is have them take it with food, start off with that way. Usually we start off with intermittent or multiple daily dosing, and once we get them stabilized, then move them to a controlled release. Usually don't start off with controlled release right off the bat. But as soon as you got them stabilized, then moving them to that may help with the GI effects. You can use antacids if you need to for upset stomach, or you can use antidiarrheal medications as well. Sometimes switching from the tablet or the capsule to a liquid formulation helps. So there's all kinds of different techniques to use to get them through that initial. Usually the gut will adapt and those things will go away, or these symptoms will go away. Nephrogenic diabetes insipidus is very common. You see 20 to 40% of people, so it's one of the most common causes of a nephrogenic DI. Polyuria is one of the most common, is the initial common presenting symptoms. Just like when we talked about nephrogenic DI in pituitary, nocturia is one of the early symptoms. They can't concentrate their urine. So overnight, you don't get up and go to the bathroom because you're not taking in fluid. The body, your kidneys can concentrate your urine, and you can usually go all night without having to get up. These folks cannot do that. So they'll go to the bathroom throughout the night. So that is usually one of the common initial presentations. If you look at the urine, it's got a low specific gravity. It looks like water. And a low osmolality as well. So they can put out as much as 3 liters a day. So that's a lot. They'll know something is wrong. Lithium accumulates. How this occurs is that lithium accumulates in those collecting ducts and makes them resistant to the effects of antidiuretic hormone. And so they just lose water as a result. So the way we treat it is really weird. We give them a diuretic. And usually we will use amelioride, which I don't think we talk about a lot, but it's a potassium-sparing diuretic. And it will sit on the same receptor that lithium does in the collecting tubules, or the same enzyme. And so it just prevents lithium from doing what it does to the collecting duct. Doesn't really affect the rest of the body or its efficacy at all. When you do that, you need to be sure you are always monitoring their fluid status and their potassium status, because those tend to put them at higher risk for lithium toxicity. So we use amelioride. You can use other diuretics. This one seems to be the favored one and better tolerated, doesn't get them into as much trouble like a thiazide will, or a loop diuretic. It works best early in the disease, so early recognition of a nephrogenic DI is important, because the longer it goes on, it can become an irreversible state that won't respond to therapy as well. If you can lower the dose of the lithium and maintain therapeutic effect, that is also a desired intervention. We don't fluid restrict them again, because that increases their risk of lithium toxicity. We also don't salt deprive them because that also can increase their risk for toxicity. Lithium gets reabsorbed in the proximal tubule as does sodium. If if you sodium deprive them, then what happens is they reabsorb more of the lithium instead of excreting it. So anytime they go into a state where they can't get water and adequate salt intake, that's one of the big risk factors for a lithium toxicity. Another one of the acute symptoms is a fine hand tremor. Pretty common, up to 50% of patients report it. Usually it happens when you start them on the drug or when you change, when you're upping the dose. The third bullet gives you the characteristics, so it's symmetrical, it's almost always the hands or upper limbs, and it's not progressive. So you would have to distinguish it between an essential tremor. The fact that they're on lithium gives you a big clue. Things that will aggravate it are anxiety, stress. We saw that with the other tremors when we talked about essential tremors. Caffeine is an aggravating factor as well. Usually resolve over time. The only key is that it can be a symptom of toxicity. So you would want a lithium level to discern whether this was a toxic effect or just one of the acute side effects. In terms of management, modify aggravating factors. So if you can get rid of some of the things like caffeine intake or stress reduction, those will be helpful. Reduce the dose if you can, rule out lithium toxicity, change the dosing form. From a long-acting to a short-acting, give smaller doses throughout the day, may help. Instead of getting a constant or an elevated level throughout the day, just see if you can lower it. Try a different salt. So lithium comes as lithium carbonate and lithium citrate. Sometimes changing the salt makes a difference. If all of those fail, then like the essential tremor, you can use a beta blocker to try to control it. Questions about those? Okay. Let's look at the long-term side effects. The two most common are renal and thyroid. Renal is a problem because it can lead to chronic renal insufficiency, can precipitate and lead to end-stage renal disease. So it can run the gamut. Thyroid is bothersome, but is very treatable, very common. The other two are parathyroid disease, which accompanies kind of the thyroid and then cardiac. So the nephrotoxicity of lithium is common. You see about a 10 to 20% of patients will have a morphologic change to the kidney due to the lithium, and I've listed those down there. Glomerular sclerosis, tubular atrophy, one of the most common is that interstitial nephritis. Risk factors go to duration. The longer they're on it, the higher the incidence is of having renal disease. The cumulative dose, so the higher the dose, the longer or the more likely. And as they advance as age, since kidney function is going to decline with age anyway. Depending on where you are in therapy, if the earlier you can discontinue the lithium, if at all possible, then some of their kidney function may return or come back to normal, or whatever their baseline was at the time, or at the time. Maybe not to what baseline it was before you started because of the length of time they've been on it. You get impaired water reabsorption, so you've got nephrogenic DI could fall into this, where they have a chronic diabetes insipidus. Let's see, we talked about use lowest effective dose. This will go with almost all of the side effects. Once daily dosing seems to help, keeping a well hydrated and sodium, and not doing sodium restriction. So baseline, you want those renal functions so that you can compare. You're going to do them fairly often early on because of early side effects or renal toxicity from lithium, and then long-term to determine the effects that it's having on the kidney. So every 2 to 3 months for the first 6 months, and then every 6 to 12 months thereafter. I'll make you a chart of the monitoring parameters for lithium as well. Okay, thyroid disease. So lithium concentrates in the thyroid, and it decreases the ability of the thyroid to put out thyroid hormones. Okay. So what do you think the body's response is? Because remember, once you put out thyroid hormone, what does it do? It exerts its effect, but what does it tell what organ does it tell that there's enough? Pituitary, okay? So if you're not making enough, then what's gonna happen?
It's making a lot more.
So the pituitary will keep stimulating that gland to put it out, right? So what lab would you get to know, to be able to figure that out? So a TSH, your T4 and T3 would be low. So sometimes what happens is that then they get a goiter because you're just keep bugging the crap out of the thyroid to do something, and it just gets bigger and still doesn't put out T3 or T4. So if they have a goiter, you would do the things that you were taught in endo to do. So doing a scan, doing a fine needle aspiration if needed. So that workup of the cause. They can get nodules. They're not as common. Goiter usually is more. It's usually a diffuse goiter. And then you can use thyroid just to settle the pituitary and get it to go back to normal. So levothyroxine T4 replacement would be a way to treat if that's the only cause. So hypothyroidism can occur without a goiter as well, and you can see up to 50%. So it's something you should anticipate that patients are going to get. It can even precipitate an autoimmune reaction. So they recommend also getting TPO as a baseline. So look for thyroid antibodies. It seems to be more likely that if somebody has already got that underlying disease that isn't clinical yet, it will spur that on or move it on to declare itself. So with the hypothyroidism, it's usually subclinical. It's not common that it's not as common for patients to be symptomatically hypothyroid. And it occurs early early in therapy, most common in women over 45 and increases with age. Kind of like we see with thyroid disease anyway. Does not require you to stop the lithium, but does need to be treated. So using a T4, levothyroxine is the drug of choice. But keep in mind, if you remove the lithium, the thyroid usually goes back to normal. So you would need to reevaluate the need for the T4 replacement. So we've talked about this twice. We've hit this several times in terms of drug-induced hypothyroidism. So here it is again. The parathyroid, so this drug causes an increase in the parathyroid gland. So they put out more parathyroid hormones. So hypercalcemia can be a finding in patients on lithium. So get a baseline before you start. In women, you can also see bone mineral density go down. Being aware of that and vigilant. It tends to be more in the forearms, not sure why, and in young patients. So you see that under 45, which would not be a common time we would start looking for that. So monitor the calcium. Let's see. If lithium can be discontinued, that would be great. The hypercalcemia will resolve. The longer the person has been on lithium, the bigger those glands get, the longer it will take for that to regress. So it can take months after you stop the drug in order for that parathyroid hormone to come back down to normal. So young patients, the forearms, older patients you're still worried, or you're worried again about spine and hip, just as we would, especially as women get into postmenopausal period. Questions? Cardiac. If patients have no existing cardiac disease, and lithium really has very little cardiac side effects, But if there is already pre-existing disease, or you have someone who's really at high risk for cardiovascular disease, and those would be what? What are those risk factors? Smoking,
High cholesterol, lipids, high lipids.
high lipids, what else? Hypertension, diabetes,
Obesity.
obesity. So those, if they are at high risk for cardiovascular disease, let's say they have metabolic syndrome, then those folks you would certainly want to follow EKGs. I've given you 3 things that are fairly consistent with lithium: T-wave flattening or inversion, AV block, bradycardia. It's recommended in the guidelines that if those appear on an EKG in a person taking lithium, you get a cardiology consult and determine the need for, the weighing the risk and the benefit of continuing with the drug. There's a whole slew of other side effects that can occur. I went with the major ones for you, and some of the other ones are listed there on top of page 6. Lithium toxicity. Lithium is really toxic, and it's a medical emergency. You have to diagnose it and get them into help. Most of the treatment is going to be supportive. If the lithium levels are really high, you can use dialysis to help. So it's discontinuing them. Gastric lavage, if they've done an overdose, then you can remove it that way. Hydration status is important, and then using dialysis if needed to bring those levels down. You can have you can have permanent neurologic problems with ataxia, memory deficits, kidney damage from an overdose. Okay, questions? Very effective drug, but very hard to use sometimes. All right.
What?
Okay, tell me what you've learned about schizophrenia. Auditory, and can you have visual? Okay. Genetic factors, okay. Does it occur early, late? Tends to be early. What else? Earlier in males.
Exacerbations can lead to decrease in baseline function.
Okay, exacerbations over time can lead to baseline decline, okay?
Paranoid schizophrenics are more likely to be violent.
They are more likely to be violent?
Yeah,
Okay. During
like,
stable times,
I guess during,
crisis,
I'm not sure. I guess during exacerbations, but I'm
okay?
not sure.
Investigators with medications can have very severe implications.
Okay, so adherence it can be a problem, okay? And if they don't adhere, then they can have more decline in function and behavior. I saw a lot of schizophrenia in taking care of diabetes. They have about a 2 to 3-fold higher risk of having diabetes than the general population. But I always love the schizophrenics because they'll do exactly what you tell them. And they don't vary, so they don't have the ability to kind of adjust their therapy based on what's going on, but they'll do exactly what you tell them. So I always like taking care of them. What else, anything? Okay. I am going to focus mostly on the side effects of the drug because there are many. And I understand from the physician just before me talk a lot about therapy and how to use it. Okay, we're going to go with what he has said. So when we look at the antipsychotics, we divide them pretty much into first generation, second generation. There's a table, I'm going to give you a different table, but this is just so you can kind of see the products. So the first generations have been around for a number of years, probably I bet you 70 years or more. The second generations are probably about 20 years or less. So the first generations are there at the top. What distinguishes them the most is they all affect the dopamine receptors. But the second generations affect them to a different extent. They tend to be able to get onto the receptor and off more frequently. And they use more of the serotonergic receptors. So the second generations tend to have less of the extrapyramidal side effects. But both classes have a great deal of other side effects. So if you look on, one of the things to note on the bottom of the page is these are the second generation antipsychotics. You'll see most of them have effects on the dopamine 2 receptors. You'll see that some of the newer agents are partial agonists, or they have preference for maybe the D3 receptor, or they don't have dopamine receptor activity at all. That's very few. And so some of that we use to our advantage when we have side effects when the D2 receptor is prominent action. If you look on the next page, it gives you some pictures of the next 2 pages, page 2 and 3, of the pharmacology of these products. So the first generation are pretty much D2 agonists, but they also block histamine, so in muscarinic. So what kind of side effects are we going to see there? Drowsiness, sedation, anticholinergic effects, and then the alpha-1 receptor, so we can see things like orthostatic hypotension. So they're not clean, and that's why we get some of the side effects we do. If you look on page 3, the second generations, the SGAs, they sit on the same receptor, but you'll notice in the second and third pictures, they get off of that. They occupy the receptor, but they move off of it. So you don't have as much of the extrapyramidal. The extrapyramidal reactions are related more to that constant sitting and occupation of the D2 receptors. On the next page, it gives you a little summary of the 2 different generations. So the first generation, the mechanism of action, the D2 antagonism. Second generation are the serotonin, the 2A, the rapid dissociation from a D2 receptor, and then the antagonist, or the agonist action on the 1A serotonin. So it shows you then the other side effects. In their first generation, you have the muscarinic, histamine, and alpha-1, and you see the very same under the second generation. So they're going to share a lot of the same side effects, and you'll see that as we go through. On the top of page 5, I like this picture because you have to have about 60 to 70% occupation of dopamine receptors in order to get an antipsychotic effect. But you'll see that the higher that occupation, then the risk of those extrapyramidal reactions goes way up. So the second generations tend to stay on the lower end. The first generation tend to stay on the higher end. That's why they have a higher incidence of tardive dyskinesias, akathisias, dystonias. So let's start with, we're going to start with the second generations first, because they're more prominent, and we'll walk through them, and then we'll go back and pick up the first generation. And then we'll talk at the end, I'm going to put together both, all the EPS for both generations. You'll see on that little picture, first generations have a higher risk of neurologic symptoms, so that's the tardive dyskinesias, the extrapyramidal effects. The second generations are more metabolic side effects. So this you can draw on other information you've already been through and diseases we've already talked about. So with the second generations, weight gain is a huge effect. And that has implications for development of diabetes and cardiovascular disease. And it can be What I saw was like half a kilo to 5 kilos over the first couple of months that the person takes the drug. I saw a lot of diabetes secondary to the second generation of the atypical antipsychotics. I would have patients who had gained 50 pounds or more on those drugs. So it's a very significant side effect. The highest ones are, they're listed are olanzapine, quetiapine, and risperidone. The lower ones are aripiprazole and ziprasidone. A lot of attention is now turning to this because the risk of dying from or having there is a higher mortality in patients who are treated with antipsychotics. And some of the thought is that it's due to the vascular and metabolic complications of these drugs. So the interventions that are listed there involve behavioral therapy, also like diet intervention and metformin. So people are getting more aggressive about putting these patients who have to go on an atypical antipsychotic into programs. So there's several that are out in the literature, but these are kind of summaries of what they have found. So behavioral weight loss intervention. So they put them into studies where there is an intent on diet, how you eat, what you eat, how often you eat, more frequent monitoring of weight. And they found that the people who were in those programs lost at least 5% or more of their body weight compared to patients who were not in those programs. The programs centered around education tailored to the population's learning capabilities. A lot of that goes to simplifying diet. I had one schizophrenic, and he would come in and we would talk about his diabetes and his diet, and he had a rule. Any meal or anything he prepared could have no more than 4 ingredients. That was it. So we couldn't talk about anything that had more than that. He liked casseroles, but only 4 ingredients. That was it. Very interesting with his rules. So group exercise, teaching them how to exercise. Small incentives, so payments or whatever. They used a variety of incentives to maybe paying for the bus fare. Things like that. Outcomes, greater proportion achieve more than 5%. Some of these patients didn't gain or they were able to lose back to baseline. I think that's huge with these drugs. So thinking about that, if you're involved in it or if you, in the use of these drugs or you're seeing patients who are on them, remembering this and getting them into programs that can help. STRIDE is a weight loss program. Lifestyle intervention. It's much more intense than the one I just described. It is very intense weekly interventions for the first 6 months, and then they go to monthly for the next year. Again, it's skills training, education. They personalize the diet. They reduce the calories, increase the physical activity. And they had quite a significant weight loss in these groups compared to the control groups. So keep those in mind. Metformin, regardless of whether the people had diabetes or not, seems to also help prevent weight gain. These folks use they use from 1 to 2 grams a day. Some of the studies used as little as 750 milligrams a day. A recent trial that I had read, after 4 months of metformin, they had lost 50% of the weight gained. That's pretty good. So consider metformin in your patients regardless of whether they have diabetes or not. Same kind of complication or same kind of side effect profile. Attention to renal function would all be important. So all those things that you've learned about metformin, when using it, you would still employ those. Hyperglycemia and diabetes. So again, schizophrenia by itself has an increased risk for diabetes. When you put them on the second generation, or the atypicals, the risk of diabetes goes way up. So it's really important to anticipate that, especially if the weight gain can't be controlled. Some people develop diabetes and have never gained weight, so it's not all the weight that is causing the increase in diabetes. So the FDA, these drugs started coming out in around 2000, 2002. By 2004, the FDA put in one of their little black box warnings, or a warning in the package insert, about hyperglycemia and diabetes. Supposedly the risk is higher with olanzapine and clozapine. I'll just tell you, I saw it across the board. Any atypical, I had people with diabetes with all of the different second generation. But it's worth noting this because if they have to be on a second generation, then you may want to move them to a lower risk. They're on olanzapine and they're really having trouble in terms of the diabetes or the weight gain, moving them to the lower risk, like the aripiprazole or ziprazidone, Geodon, or I can't remember Abilify is the other one. So there were also, at that time, when the FDA came out with its ruling, the American Diabetes Association and the American Psychiatry Association put together a guidelines for monitoring. And they include a baseline weight and BMI, and following that every time you saw the person. Also blood pressure, fasting triglycerides, fasting lipids, asking the patients about a history of diabetes, and in screening for diabetes is important. Medicare in the last, Mark, when did that come out? Medicare's with that quality measure.
It's been about a year, maybe year to 2 years.
Okay.
They do that.
Did you talk about primary care within psychiatric
We
care?
haven't talked about it yet, but what she's referring to is that there are
Oh,
now.
I'm gonna tell him. I've got it in
We haven't
here.
really gotten into it, but she goes into it, but it's become a big thing.
Right, so we were talking about this last night, that in psychiatry, the care of the patient medically is really not emphasized. So it's really important that patients who have psychiatric disease have a good primary care because of just the risk that they have for other metabolic diseases, and then the drugs that they end up on have lots of health consequences. So because this problem has become so significant, Medicare, which is going to be the payment vehicle for most of these patients, has come out with what they call a quality measure. And it's in that first paragraph on page 7. So they are now required, psychiatric hospitals, if they discharge a patient on a antipsychotic, they must meet these criteria. So they require the hospitals not to just check a box and say, yes, we did that. They have to submit the data on the patients with regards to their weight, their BMI, their blood pressure, their blood glucose control, and their lipid status within the past year. If they don't submit it, then they don't get reimbursed. So they're hitting them financially for not doing this. So there are a lot of pharmacists who specialize in psychiatric pharmacy. And a lot of them do this, will take over making sure these things are monitored and carried through. Zane, I understand your brother is a Psych PharmD.
Yeah, he's about to start in Oregon well, he worked at the VA in Lexington.
Oh, wow.
And in the psych department, and then he just got a psych job out in the VA in Oregon, so he's
Okay.
moving out in, like, I think a week.
So is he just out of training?
It's Medford, Oregon.
Medford,
Oh.
Yeah.
okay. I went to Roseburg, VA.
Yeah, you said previously that it was pretty close to Crater Lake,
Yeah,
and he's pretty close to that, so I thought it was the same one, but I guess not.
it's not, but
Yeah.
man, there's a lot of little VAs out there.
Yeah.
So a lot of pharmacists have been charged with being in charge of meeting these quality measures. Just to, let's see, a few things. We'll finish up with the metabolic and then we'll take a break. Well, that doesn't mean you can go. If you have to go. But several of you are getting up, so I thought, well, I'll just give you a heads up. So based on these monitoring parameters, you could switch them back to a lower or a lower risk. Second generation is one way to do it. Let's see. If your patient has prediabetes or has risk factors for the development of diabetes, then your monitoring may want to be more frequent or more intense. Another problem is that these patients can present in DKA the first time before they're ever diagnosed with diabetes. And I'm going to show you a case of a person. I had it with almost all the drugs, and I bet 40% of the patients I saw that were on atypicals, their first presentation was DKA. The problem with this is that they do not look like the typical DKA patient. So they may be older, they may have different race, from different racial ethnic groups that are low risk for usually type 1. They're usually heavier. And so when they present, it isn't necessarily what people are thinking. And so the diagnosis may be delayed and the mortality goes up when that happens. So these drugs are very good at what they do, but healthy respect for also the side effects that they can do. When you treat somebody who has a drug-induced diabetes, or you're going to treat them the very same. So the drugs are the same, the approach is the same. Most of the ones I saw were on insulin, but I think that's because by the time they had run through everything they could do, that they sent them to us. So the treatment approach would be similar. They don't know if these drugs necessarily are causing the diabetes, or it's the metabolic consequences of the drugs that do it, or if the person was already going at high risk for diabetes and this just helped it to manifest. So it's not necessarily categorized as a secondary cause of diabetes. So you're going to treat them just like you would any of the other folks that we talked about. Let me show you this case. This was a published case of a patient who was on an atypical. Very sad case. Whoops. So this is a 45-year-old male. He had known schizophrenia. He had been placed on, he was actually on 2 atypicals, clozapine and risperidone. He had been on them for 3 years. And he was admitted to the emergency room unresponsive. Prior to admission, he had complained of severe thirst, exhaustion, frequent urination, and had a 5-pound weight loss in the last month. He was described by the ER physicians as being emaciated. So he may have had a slow decline and then an acute episode at the very end. He was unconscious on admission with a respiratory rate of 8 breaths per minute. Does that sound like when we talked about like DKA in the past?
No.
No, but he has severely had respiratory depression. And his blood pressure was 60 over palpable. His ABGs, he had a pH of 6.9. What's normal? 7.4, so he has a what? How do you characterize it?
Acidosis.
It's an acidosis. His PCO2 was 32, so that was elevated, probably because of the respiratory depression. He had other things going on as well. His bicarbonate was 6.1. What's normal? About 22 to 30. Yeah, 22, 28. His serum creatinine was 2.8, so very dehydrated. BUN of 102. So what's that tell you? That BUN to creatinine ratio is what? About 30 to 1. What should it normally be? Less than 20 to 1. So very azotemic, pre-renal cause. His sodium was 125, why was that? What's his blood sugar? 416. So what did I tell you about hyperglycemia and sodium?
There's a correction factor.
There's a correction factor, what is it?
100 for every 35 over.
That's A1C, so 1.6, well, I know, there's too many correction factors we're talking about. So 1.6 for every 100 over 100. Or is it over 200?
Over 100.
Over
I think
100.
100.
Okay, so what was his? He's 3.1 times 1.6. Somebody have a calculator? .8, about 5. So you add that to here, and so his corrected is about 130. Is that normal? All right. He's still a little bit low. His A1C was 8.9. His urine was positive for ketones and sugar, and he had a positive family history for a type 2. He was septic, which is probably what led to his demise. He was treated with antibiotics, fluid, insulin, and he died within 48 hours of admission. But an unexpected DKA on top of a probably known type 2. All right, 2 other comments. Hyperlipidemia also increases in hypertension, increases with the use of these agents. You treat them the same as you would according to guidelines. You treat his hyperlipidemia based on his risk factors, and using a statin would be appropriate, and then the other for hypertension, you would use current guidelines. So all of that, none of that changes. But it's really important, if you are the primary care for this person, to pay attention to those cardiovascular or whole metabolic picture and treat them for all of those. Because it's rare that you can take the drug away. And none of them are going to be without cause. So even the lowest risk of these will still have more milder metabolic effects. Question, somebody had a question on it?
So he had undiagnosed type 2 and then he was put on the second generation and that perpetrated his DK and that.
He had no diabetes status prior to this presentation. This was his first presentation of diabetes, so he had no known. Probably had never been checked.
Okay, so
Wasn't symptomatic until about the last month. And then got septic, you had both on top of each other. The septicemia probably accelerated the DKA.
so if a provider had gotten A1Cs and stuff before they put him on the SGA, that wouldn't have happened.
If they had been, it still could have happened, but if they had been monitoring and controlling his blood sugar, less likely that it would have happened. Other comment? All right, so let's take a break. We'll come back at 1:45.